Next we have Dr. Faisal sir. He is an additional professor in PGH and the CUD. He's a very familiar face in national conferences, and he'll be talking about glaucomatous disc dilemma, clarifying with OCT.
Yeah. So very good afternoon everybody, and first of all I thank the Fahim and the KSOS, and I thanks the other co-instructors also. So I'm basically practicing glaucoma, so I'll be touching mainly on the glaucoma parts. So we know the optic, what is the optic nerve, why the optic nerve is so important, because it acts as a magic camera which connect the retinal ganglion cell into the processing unit, that is the brain, and it form a nice view of nice images in front of you. So why glaucoma? Glaucoma is, we know, one of the irreversible blindness worldwide, and it's a progressive optic neuropathy. And in glaucoma, always the structural changes precedes the functional changes, so that, like Fahim already mentioned, that there is 30% of ganglion cell loss happened before it can be detected on a visual field. So you will have a good window if you detect very early. So imaging, he already brushed up, and it can be detect abnormality, and also objective. It will be useful for objective follow-up also. And for eye, eye, it can be anterior segment imaging or posterior segment imaging. For posterior segment, we have retinal scans, optic nerve, optic disc head, and retinal ganglion RNFL scans, and the macular GCC scans. So for protocols for glaucoma, mainly optic nerve head analysis, RNFL analysis, and GCC analysis. So a normal printout, a OCT, typical OCT, the Zeiss OCT will give a printout like this combination of optic nerve head and the RNFL. This is the RNFL and the optic nerve combined printout. These are the various parts he already mentioned. And the GCC, why GCC is important? Because 50% of your RGC will stay within 4.5 millimeter within the center. So the RGC is very important, and it's thought to be less influenced by the tilted disc or myopic elongation. So GCC is also now part of OCT evaluation, which is more relevant in recently. So as he already mentioned, that the temporal fibers which strictly respect the horizontal raphe, so or any asymmetric changes which lead to formation of a temporal raphe sign, which is also initial marker of the glaucoma. So in SDOCT, in serous OCT, we have a GC, which means sum of retinal ganglion cell layer and internal plexiform layer. So the color coding is, he has already described, it appears the same. So what's a normal? A normal is, here is a 60-year-old male patient with normal looking disc, pink disc, and the OCT appears like all parameters are looking normal, and corresponding will always match with the, just don't see the OCT only, match with the disc picture and the visual field also. So look at this disc, it can pass, this has maybe a normal disc, field is not much contributory in these patients. And look at the OCT in the right eye, there is quadrantal map shows some yellow signal. If you see carefully the disc, the superior margin has lost its normal sharpness, which the OCT picks is labeled as early glaucoma. So in the next patient, here is there is in right eye inferior notch along with inferior RNFL defect, and the OCT picked very well the inferior notch in the quadrangular map also, and the temporally there is a thinning infratemporally, which is highlighted in this picture. This is the temporally, there is a changes, and the OCT inferiorly also there is thinning. So here is a young male seroresponder. You can see there is inferior notching and the corresponding RNFL loss very well marked, and the OCT also picked very well, but the GCC area appears normal. Why? If there is a changes in the superior inferior pole, that may not be representing the GCC, because these fibers are not reaching or not coming from the central ganglion cell area. Whereas this patient, 62-year-old female, primary angle closure disease, she came later on to PSCG, there is disc hemorrhage inferiorly. If see the counter cup, there is notch, even touch of the inferior margin. So and the OCT shows there is inferiorly there is global thinning, and along with this typical temporal changes, the temporal raphe sign, because this is a wider inferior area of loss, which also include the central fibers, inferior central fibers also. And the advanced glaucoma, the pictures like this, but the advanced glaucoma, the problem is the floor effect. After a particular range of loss, the OCT won't be much useful for an advanced disease. The advanced disease, you have to come back again to the visual field again. So, as he already mentioned that here this patient, if there is a small inferior notch and there is RNFL loss also, wedge defect also, little periphery. But the OCT passed it as a green and not picked the quadrangular areas not picked the defect. But on seeing the the thickness map, see there is a this bluish coloration, that means there is thinning. So the OCT, the thickness map picked the lesions, but the quadrant map or the clockwise map passed it as a normal. So see the printout as a whole, not only the quadrangular or the the clock hours. Another case, here see the inferior, there is an inferior notch and the OCT picked well. But the superiorly, there is a wedge-shaped RNFL, small RNFL defect, which is more appreciated in the red-free photograph. But the corresponding OCT side appears normal. But on seeing the, again the thickness map, the OCT picked the area. But for this, statistically, this area is coming and fell within the normative data. That's the machine labeled as a green, though there is a definitive RNFL loss. Correlate clinically. Don't be foolish by just seeing the redness or red disease, like red area in the OCT. Here is a normal looking optic disc, and there is the macula, there is retinal lesions, which is more appreciated in the macular, macular OCT. So always correlate, always see the fundus as a whole, just not seeing the RNFL area or the corresponding OCT. So another example here is the optic disc appears normal, but there is, there is inferiorly. There is this temporally there is defects, but it's not look like a typical temporal raphe signs. So if you see the fundus, there is old vascular changes, old BR view. So that's why looking the eye as a whole clinically is much important. Just seeing not only seeing the OCT only. As he already mentioned, peripapillary atrophy, the OCTs may not be much useful because you will get all kind of funny pictures like poor segmentation, all kind of, and the weird kind of thickness may be very high, very low. So in this peripapillary atrophy, you follow the optic disc counter and optics changes periodically and correlate with the clinically, and OCT is not much useful in the peripapillary atrophy. Here is just last week this patient came managed as glaucoma, but on carefully seeing the disc was found to be symmetrical changes. This is more of a disc anomaly rather than a glaucoma, and the OCT is like funny, like a poor segmentation, cannot identify the structures, but the GCC is relatively good and the thickness is all within the normal limits, and for patient followed without medication because the symmetrical changes and patient already had epidermal cyst excision, this kind of congenital anomalies. So be careful and correlate everything together and just not label the disease glaucoma with just seeing the OCT. And this is all steroid responder. This looks normal, like there is more of small crowded disc, but the OCT in the right eye shows some changes, but the RNFL defect also missed, and the OCT in the spectralis picked the lesion. There is small thinning in the right eye. But contradicting this picture, there is another case of steroid response, another case where a patient with very large pressure, left eye the cup, both eye the small cup, but the left eye there is cupping. There is also the RNFL normal sheen of the RNFL lost inferiorly, but contradicting the OCT shows green. What is OCT not picked the lesion? Because I already mentioned that for that particular patient everything has been crowded, and statistically this thickness fell within the normal region of the normative data. That's why the OCT labeled it as green, even though there is disc appears to be glaucomatous and the evidence of high IOP and visual field changes also. So this is a large disc. Large disc also okay. Sometimes you may label as glaucomatous disc. On corroborating with the OCT appears normal and the visual field also appears normal. Here is another patient. Disc appears okay, good neuroretinal rim, good color, but the OCT is not for some redness, especially in the quadrangular map and the clockwise map. But on careful evaluation, you could see there is haziness, which is more likely appears due to posterior vitreous detachment, which falsely segmented the OCT. So this is another patient. Left eye can see there is disc hemorrhage, optic neuroretinal thinning, and the RNFL loss, but the OCT appears normal because there is a disc hemorrhage. There can be a optic disc edema also, which OCT can label as white or green. So there is a definitive glaucoma, but the OCT appears as green. Temporal pallor, you can see there is temporal pallor. The GCC out of proportion to the disc finding or the optic RNFL change, optic disc changes and the optic parameters, then they think about other parameters. And on one case for optic neuropathy referred as glaucoma suspect, and this is GCC appears the vertical follows the vertical meridian, and the field also correspondingly and is found to be a neurological. Can be used for progression. You can sit the machine and you can add more data and data. You can get the glaucoma progression analysis. Even if you don't have progression analysis, you can follow. This is two cases. The first patient, there is minimal temporal raphe, and after 1 year, this defect has been now become reddish, and the temporal raphe size has been increased. And the second case, there is a ocular hypertension, very high pressure. On serial follow-up on the GCC area, initially the defect was in the yellow range, then it has been increased to red, and which suggestive of OCT also can do a significant contributor in the follow-up of the patient, especially in the early period of the glaucoma. So summarize, approach should be individualized and correlate well with clinically. Redness means maybe glaucoma or previous incident of past insult of glaucoma or non-glaucomatous cupping or maybe due to bad scan. Green on imaging is not always normal. Keep in mind that. Thank you. These are my mentors and my colleague and my senior resident for contributing these various pictures and data. Thank you.
Thank you, Faisal sir, for that excellent presentation. He has covered the topic extensively.